Hello, I'm Michelle Lavander, Director of the USC Center for Health Journalism. Thanks for joining us today and welcome to our Health Matters webinar covering coronavirus, aging and alone during COVID-19. With the holidays around the corner, we will be discussing loneliness and isolation among seniors. This is always an issue at this time of year, but with the pandemic still raging and vaccines only just rolling out, seniors are confronting tremendous vulnerability to loneliness, a condition that can be deadly to their health. Seminal research by one of our speakers today, Dr. Carla Perissinotto and her team, has shown that loneliness can lead to a precipitous decline in seniors' ability to perform basic daily tasks and even hasten their deaths. Isolation already was a growing problem among older adults before the pandemic struck, with 43% of elderly adults reporting feeling lonely in her large national study. During the pandemic, government agencies, nonprofits, and ad hoc volunteer groups have launched a host of hotlines, phone banks, and other programs to connect with vulnerable seniors, with millions in expenditures involved. But there is a surprising lack of knowledge about which interventions really work. The stakes are high. In this webinar, we'll talk about how loneliness and isolation can impact older Americans, how the pandemic has exacerbated the crisis, and where we can go from here. You'll also learn about policy and journalism strategies for covering this important and often overlooked topic, and we'll explore the unique challenges for seniors of color and best practices to serve them. We're going to start out with Dr. Carla Perissinotto, who's going to paint a bit of a landscape for us.
All right, looks like I need permission to share my screen, or I think you need to stop share and then I can.
Just give us a moment.
Sure. There we go, great. Okay, let's see where we are here. Okay, here we go. All right, nice to be with everyone today and thanks so much for joining us. What I'm going to do in a couple minutes is really start first by talking about definitions, just to make sure we're all on the same page about what we mean by loneliness and isolation. We'll talk a little bit about
Dr.
measurement.
Just so you know, we're seeing your notes too.
Oh, you are? That's
yeah.
weird. Oh. Let me see. Huh. Give me a second. That's weird because when we just tried it, it didn't do that. But give me 1 second. No. How's that?
That's perfect.
Better? Okay.
But you might want to go back to your first slide.
I think we're good.
There you go.
Yeah? Do you have that? Okay. Technology always gets me. And we're then going to talk a little bit about the experiences of loneliness and isolation during the pandemic. And then lastly, how do we actually meet the needs of our population? So to start with, what we're talking about when we discuss loneliness and isolation. So the important distinction here is that loneliness is something that's subjective. It is a subjective assessment or the discrepancy between perceived and actual relationships, or what we also say is the distress that someone may feel when the relationships that they actually have are not what they desire. This is in contrast to social isolation, which is really something that's an objective measure of the number of relationships. If we think about what's going on with the pandemic, many of us are being forced into social isolation because of the physical distancing we're having to have. So this means that maybe we used to have 10 people we saw regularly, now it's down to 0 or 1. A congregate term to think about this is social disconnection, which really encompasses all of both these terms. And then if we got into more nitty-gritty, which we won't do right now, there are even more subdivisions in these definitions, which are emotional, functional, and structural aspects of loneliness. And what's important about this is that this ultimately affects how we address this issue. When we think about measurement, and what we mean by measurement is how do we actually know the degree of someone's loneliness or isolation? So the first thing we need to do is ask ourselves, are we talking about loneliness or are we talking about isolation, or both? Because we use these terms interchangeably, but how we define and measure actually ends up impacting our outcomes and what we do. The second thing is identifying our population. Who are we talking about? Because different populations have different risk factors. The third part is the mechanism. So how someone may be lonely or why may be different from person to person. And similarly, why or how someone is isolated may be different. And our solutions will differ depending on the mechanism. That also makes us think about, when we're talking about solutions, understanding why we think that intervention or solution might help. For example, if we've determined that someone is both lonely and isolated because they live in San Francisco with stairs and they don't have transportations, well, that is the mechanism for their loneliness, which also means that the intervention will have to match why the reason the person is lonely or isolated. And then ultimately is measuring and implementing in terms of what then do we do to solve this. When we're talking about measurement and identifying, currently there actually is no gold standard for screening and evaluation. There are recommended tools. All of them have benefits and drawbacks. The most commonly used here in the United States are the UCLA Loneliness Scale, the Berkman-Syme, and the Duke Social Support Index. There's many others, as you can see listed on this screen, but those are the most commonly accepted. There is a new screener called the USIRS, which is the Upstream Social Isolation Risk. That is new as of in the last couple of months. We're still trying to see how it works and how it can be adapted to multiple populations. We would love to see a congregate social disconnected measurement tool, and perhaps this is what the USIRS is getting at, but we do not have anything that's widely used clinically yet. So what are the risk factors for loneliness specifically? Well, when we think about risk factors, we always think about, is there a genetic component? Is there a biologic component? What's going on in the environment? What's going on in the lifestyle? There are multiple things here. We do not yet know of any genetic component. In terms of biology, well, it depends on how you think about biology. We certainly know that there are increased and higher risk for people who are older age, women, and the question is, with women, is that something that's really biological, or is it more of a social construct because of environmental and lifestyle circumstances? The other things that we know that are risk factors are, we know that people in traditionally underrepresented groups, which may vary also by location where you live, may have higher risk factors, LGBTQ older adults, and then there's a few other things, but those are the main ones I wanted to highlight. What does this ultimately mean? Well, there's a plethora of research that actually goes into how loneliness affects health, and similarly how isolation affects health. My research started or was published in 2012, showing that loneliness specifically had an increased risk of mortality and loss of function. When you look at the research, what's a little bit challenging is to get at, is it loneliness or is it isolation or is it both that affect health? Ultimately, it's both in varying degrees. The research is a little bit mixed in terms of the outcomes, in part because of what we started out talking with, which is the definitions are often used interchangeably. And so the studies are a little bit difficult to tease in. But the bottom line really is that loneliness and isolation are bad for our health. We see this in worsened outcomes for heart disease, worse control of diabetes, things such as poor sleep and depression. We're seeing increases in frailty and functional decline, notable increased risk of Alzheimer's dementia as measured by cortical burden, amyloid burden in the brain. And ultimately, which is important for our healthcare system, is higher healthcare costs and increased mortality. From this slide, what I think is really important about what's going on in the pandemic is if we think about our older adults who are living in any type of long-term care facility or even at home, is that we're seeing quite a bit of functional decline. I spoke to one of my patients just on Monday who's in his 90s, who before the pandemic would walk around his neighborhood pretty routinely. But now, because he's so afraid of going outside because of people being unmasked, He knows that he is having more difficulty walking. He used to be able to get up from a chair quite readily. Now he has to do more of a rocking motion to get up, which is a sign of him losing his function in his legs. So these are not insignificant things and things that we're seeing right now in the pandemic. The underlying causes or how this affects our health, we think the theory is that there's this chronic inflammation or an increased stress response in our body that affects all of our organ systems and ultimately how we lead to health outcomes. One of the challenges with this research, and specifically what's going on during the pandemic, is we don't exactly know how long do you have to be isolated or how long do you have to be lonely in order to see these negative health effects. I think from the pandemic, what we're seeing is function is very quickly deteriorating. There's some postulation that cognition is changing rapidly, especially for our folks in long-term care who are not having as much socialization, but we don't know exactly how severe it is and whether these are now irreversible changes. So what are we seeing right now during the pandemic? So my colleague Ashwin Kotwal and a few others, including Julianne Holt-Lundstedt and I, have been conducting a study in the Bay Area over the last several months. We were specifically looking at San Francisco, but there's several adults in our study from around the Bay Area. We recruited people from different sites, from our UCSF clinics, and then from two community programs, Covia and Curry Senior Center. We actually started collecting data and enrolling people right after, very soon after the first shelter in place of March of 2020. How can I forget 2020? I feel like I shouldn't forget that number, but somehow I'm trying to. We were collecting information every 2 to 4 weeks, and we did this frequently because things were changing so rapidly that we had suspicions that people's mental health and their experience of loneliness and isolation would change pretty dramatically. So we asked quite a few questions about their psychological well-being, what kind of social connections they were having, and what medical needs they were experiencing or gaps. We had about 151 respondents. Again, as I've been saying, we've been following them longitudinally. The average age was 75. You can see the ethnic breakdown here on the left, predominantly white, but still a decent number of African-American, Hispanic or Latino seniors, Asian, and then 9% multi-ethnic, which is somewhat representative of San Francisco, though not quite, but better than some of the other research I've seen that unfortunately don't include a diverse sample. The predominant amount of this people in the sample were women. At 64% of our sample, more than half of them lived alone, as you can see, and many were experiencing comorbid or coexisted depression, anxiety, and functional impairment. So in some ways, a pretty classic older adult geriatric population, but in some ways, perhaps more low income and more functional impairments. So what have we found? So at the beginning of the pandemic, we found that 29% of our sample had frequent feelings of loneliness. This is, depending on what research you look at, pretty on par with what national research has shown. In my study from 2012, 43% of the population we surveyed had some degree of loneliness. And then what we also found in this sample is that because of COVID, 51% of people found that their loneliness was actually worse. And we'll get into a little bit about who is this segment of the population. We also noticed things that people were having worsened depression, worsened anxiety. People are very worried about COVID and very worried about getting delays in their medical care. So some of this may not be surprising for us, but it's helpful to see it in actual numbers, what we're talking about when we see that there's postulating that things are worse. So the general patterns that we've seen in our study is that during the pandemic, there's a subgroup of people whose loneliness has certainly worsened. And an example of this is for a woman who said that before the virus, she was socializing quite a bit, but now she's more lonely and isolated. And with regards to technology, she says, I like technology, but I have trouble keeping up. But I'm totally out of date. And I think this may be indicative of what many people are experiencing. There's another group of people who have been lonely even before the pandemic, and their loneliness levels remain high. And what they say is, this has been the hardest thing I've had to do in my entire life. And someone literally says the isolation has made my mental and physical health worse. So someone literally experiencing what we're most afraid of is this worsening. And also noting the environment around her, that people are more on edge, which is certainly true. And then the third group is a group of people whose loneliness is relatively mild and saying, well, in my assisted living, I'm pretty isolated and we're confined, we're safe, but life is pretty dull. So that's probably an understatement, I would say, but good to know for this person that it's not an overwhelming symptom. What else did we find during our study? Telephone communication has been the most common way people are communicating during the pandemic. Concerning in our sample is that 79% of our sample had minimal to no video interactions. And the reason that is important is because, as you all know, many of the social programs that people may be relying on have moved to virtual. And when you think about medical care, the majority of care has moved to virtual. So this makes us think about who's being left out. And are we making a mistake by moving everything virtual? And do we have to think about what kind of in-person care can we still do in a safe way? 43% of the sample specifically had minimal internet use. What we were not sure of here is this because of, is it access issues in terms of broadband or because of socioeconomic reasons, or is it just lack of desire or lack of knowledge? And this is something to tease out. The other thing we found, and I'll get to this a little bit, is that the adults who reported feeling isolated had substantial unmet health needs. And this is probably one of our biggest fears as healthcare providers. So how do we translate some of these findings into practice? And what does this mean for us every day as clinicians, as community members, as legislators, as family members? So I wanted to point to a report that came out in February by the National Academy of Sciences, which really looked at what is the opportunity for healthcare systems to really address loneliness and isolation in older adults. So their conclusions are, their major five conclusions are that we need a more robust evidence base. The evidence base here that we're referring to is more on the solutions and intervention side, because the evidence on the risks and the health effects are very strong. The second area is, how do we translate current research into healthcare practices? What that means, for example, is in my research, which showed that loneliness has effects on death and functional decline. What does that mean for me clinically? How do I then translate that into something that's actionable in a healthcare setting? The third thing is increasing awareness or improving awareness of this topic. And thankfully, this is why you are all here, to help spread the word. And I think we've made tremendous progress in this arena. The fourth area is strengthening ongoing education and training. And this is in all settings. For my work as a physician, this means that when I work with medical students or residents, it's making sure that when they're assessing patients, that they know that this is something that we need to assess and that they have to place just as much importance on someone's social risk factors as some of their other traditional medical risk factors. And then the last one is strengthening ties between healthcare system and community-based networks. So this means that as a healthcare provider, I need to understand what is available in my community, what has evidence, and how do I provide solutions and opportunities for my patients to have improvements. In a little bit more concrete terms, what we have found during the pandemic, and tying this also to the National Academy of Sciences report, is that many older adults are experiencing worsened loneliness, but it is not universal. So that is in some ways positive, but still concerning. From the National Academy of Sciences report, we know that this probably means that we need to actually be periodically assessing our older adults and potentially even larger segments of the population using validated tools. So in my practice, I use the UCLA 3-item loneliness questionnaire, and as recommended by a prior report by the Institute of Medicine, using the Berkman-Symes Social Network Index. And then again, there's this question of the users. The second thing we've noted is that there's a marked digital divide. So this again means that we have to be careful with not overutilizing technology-based solutions, or thinking about who are we leaving out and how can we help those people get back in the mix. This also means, tying it to the National Academy of Sciences report, is how do we identify those that are going to be at highest risk, either because they have an acute change in their loneliness or this is something chronic, and how do we better target interventions based on this? The third thing is that if we screen or evaluate our population for loneliness and or isolation, we have to think about why or how they may be lonely, as I started the presentation with, and target our interventions based on that. The United Kingdom has quite a bit of evidence or experience on what is called social prescribing, which means that you're identified by your healthcare provider as being lonely or having loneliness, and as part of a healthcare benefit, for example, you may receive a resource to address that. And then lastly, it's thinking about, as we start to see who's lonely and isolated, we understand that there are unmet needs. So in our study, we found that over 70% of people had trouble accessing medications in a timely manner. And it also may mean, as I mentioned, that we may need opportunities to facilitate technology. And food insecurity, as we know, is a big topic these days. And this again ties to the National Academy of Sciences report. Okay. So in summary, we know that loneliness and isolation are common, and we know that COVID is actually making it worse for some. We also know that things like serious illness, caregiving, and end of life are raising unique challenges. And we know that the end of life care is incredibly complicated right now, both for the person dying and for the family and friends left behind because of isolation issues. We have opportunities to reach many people. It's just have to making sure that our programs reach the right people at the right time. This is an absolutely an amazing time for awareness and advocacy. So make sure you speak up for those who can't, make your voices heard, and remember that connection is an incredible, powerful way to protect our lives and our health. And like any new mother, I hear you have to share a picture of your child. So here's my child, Gianna, who is 5 months tomorrow, wearing her sous chef outfit because her father is a chef. So that is my connection. Thank you.
Thank you so much, Carla, for this really wonderful summary. Before we hear from our other panelists, I want to share a few details about our speakers and the program. Dr. Carla Perissinotto, who you just heard from, is a geriatrician and palliative care physician and an associate professor of medicine at the University of California, San Francisco, where she serves as associate chief for the geriatrics clinical programs. Paula Spann writes the New Old Age column for the New York Times, which focuses on aging and caregiving, and she's a faculty member at the Columbia University Graduate School of Journalism. And Laura Trejo, who we're going to hear from next, is general manager of the Department of Aging for the City of Los Angeles. She leads Purposeful Aging LA and serves on a host of national and local boards related to aging. So the other thing I just wanted to mention is that if you want to tweet about this, the hashtag we're using is Aging Alone, and we will be turning to questions from participants at the end of the panel discussion, and you can put your questions at any time in the Q&A part of Zoom. So Laura, I'm going to turn to you. In your role as general manager of the Department of Aging here in the city of Los Angeles, you're working with seniors who, are facing so many risks and vulnerabilities. And where would you put loneliness on that list of risks and why?
Currently, we're putting it as one of the top priorities that we're concerned about. I think one of the two areas we're very, very worried about, it has to do with food insecurity and social isolation. So a lot of our work in the last few months has been really to address how we pivot and reprogram and intentionally create solutions that support older persons staying in the community and staying connected through our programs and our services.
Thank you. And Laura, you're overseeing aging programs in a majority minority city. And I'm wondering, how does that inform the approaches you take when trying to combat loneliness during the pandemic? And does loneliness and isolation play out differently in the different communities that you're working with?
I will answer your first question about, how does that inform our work? It informs it on a moment-to-moment basis. It is always present in our thinking. We work in communities that speak on average 9 to 12 threshold languages. So intentionally, we have to be thinking about accessibility. I can tell you one of the things I did at the beginning of the pandemic, I literally took my native speakers of different languages in my office and I had them call a series of organizations that we would be more likely to be referring to. And I said, I want you not to speak English. I want you to pretend that you forgot how to speak English. And I want to see what happens and just jot down your experience. And to the person, and I said, you're supposed to be my 80-year-old mother trying to access services. To the person, they came back saying, I think we have a problem. We need to talk to our partners, because I knew that I could speak English at will. But if I did not, I would not have had a successful contact. So we began to talk to our colleagues. We began to develop different relationships, for example, with Native Asian Pacific Islander groups who were particularly concerned. So we reached out to the National Council on Asian and Pacific Islander Seniors, so that they have language lines that we could refer to. What we were trying to figure out is how to make sure that people were not being falling through the cracks in our safety net. And so in Los Angeles, that's every day. You know, our purposeful aging work, we actually did a survey in 9 threshold languages. If anybody's interested, look it up. It's online at purposefulagingla.com. And it's all on there, and our findings are there. And so we think about it all the time, and it's very intentional in the work that we do when we're thinking of programs. You know, we want to make sure that programs are available and accessible in the language of preference of our clients. So to the degree that we can do that, we always try to do that. The second part of your question was, how does that inform our understanding of how loneliness or social isolation is expressed in different communities? I think we don't know that answer very well yet. There hasn't been a lot of research done with ethnic minority older adult populations in particular. I think we're still trying to understand how it works in majority older adult populations. Anecdotally, we do hear it, you know, that older adults are experiencing additional isolation because they have language and cultural challenges that may not be as accessible right now for them in terms of the support. So we're trying to work with our partners in the communities to make sure that we're accessing these seniors effectively.
And you said something very interesting when we spoke the other day, which was this idea that you might have more seniors in a city like LA that are living in multi-generational households. Does that make them more lonely or less lonely during the pandemic?
You know, again, it's not an issue. Remember, doctor was talking about the difference between loneliness and isolation. I think many of our seniors are isolating, even within multi-generational households. I can tell you again, from talking to colleagues across the city, folks do report that families are being very protective of older people, and trying to stay away from visiting. You know, they're doing the drive-by and the front porch talks with mom. I literally had an elderly colleague say to me that she had seen on YouTube this plastic thing that she created so she could hug her son. And so I am seeing that communities are becoming creative to provide that social connectedness and contact they need. Whether or not they're lonelier, I could not answer that.
I
Yeah.
wanted to just add to, if it's okay, what
Sure.
Laura is saying is that, you know, the National Academy of Sciences report, one of the things that we were, and I was a committee member, one of the things we were tasked with is really understanding underserved community and communities of color or ethnic communities. And that is absolutely one of the biggest gaps in the data, in the literature, is really understanding more about these populations and specifically how to target interventions. I know that, you know, San Francisco is also a pretty diverse city. And one of my biggest challenges as a clinician is if I have some of my own patients from ethnic groups that are smaller and not as represented, it's very hard to find programs to suit their needs. And I have some patients who are isolated literally because of linguistic differences and where I can't find programs to meet their needs. I will also say the other thing that's important, I think exactly as Laura said, is in the study that I conducted and published in 2012, the majority of people who reported loneliness were living with other people. So while there is hope that some cross-generational mixing is good, we don't know exactly what that means. And we don't know, every family situation is different. I've also had the experience of my patients' families being incredibly protective, and there were months before I was allowed to see some of my patients, and that was very problematic to me because I saw some of my patients have deteriorating health because their family members would not let me in their home. I provide home-based primary care. So very complex issue here. And the balancing of protecting older adults against COVID, but potentially increasing greater risk by preventing socialization is very real.
Very much so. Thank you.
So this is just a terrible kind of dilemma to try and balance those two efforts. And I'm wondering for you, Laura, pre-pandemic, you had a lot of innovative and very culturally sensitive programs here in LA, which were all based on doing things in person to end isolation. So how have you pivoted? What have you done to serve those populations now?
The aging network is incredibly resilient, just like our clients are. And so our providers, our partners began almost immediately to reevaluate the offerings that they were doing face-to-face at the centers and began to translate programs into, as some may consider low-tech, conference calls has become very popular with our age group, where rather than just relying all on internet, I think the doctor said that very effectively, that may not always be the answer for this age group. So we're trying a mix of things, virtual clubs online, but we're also doing conference calls with like 4,000 seniors in Los Angeles. And, we do a few minutes of a lecturette and then there's a lot of interaction. So we're also trying old school stuff. We're sending out flyers and postcards with their meal. We're redesigning placemats so that they're fun and they can read them and call us about it. So we're trying different approaches so that we're staying connected and keeping our clients connected to us. And I'll give you one small example where it gives me hope that it's working. One of our seniors that we've been doing food delivery to, she lives alone. Nobody knew she macrameed, and she made these beautiful hearts and left them in a little bag outside of her doorstep with a note for the meal delivery person. And she said, "Thank you for showing me so much love. And this is what I'm giving to you." And there were 2 little hearts that she had made. And I can tell you, for me, that was very touching because it said that our efforts to connect with her were working. She was seeing the connection being really present and she wanted to reciprocate. So those are small ways that we measure the impact that we're having in the community.
And Laura, you have, vans that go all over, you or the nonprofits you work with that go all over LA to bring people to doctors and senior centers and so on. What are they idling, or what's happening with those sorts of?
I call it repurposing. That's my government term for it, which means that we've called them into action in other ways. For example, our vans are being used to deliver meals because we are now we were delivering meals to about 5,000 people, and now we have over 20,000 that we're delivering to. So that created a need for us to have a different way of deploying those resources. We've also are using, for example, we work with the county to transform one of their transportation programs to do grocery pickup. When people call the grocery store, instead of paying the fee, we'll go pick it up for them and deliver it to their home. So that way for low-income seniors, that becomes more accessible as a service other than having to pay a fee for that delivery to occur. So we are looking at our existing resources and trying to figure out how they meet the need during this incredibly challenging time. And that's been going on in all levels of the work that we do.
And I have one other question for you before we turn to Paula Span of the New York Times, which is, you mentioned technology, and in all these different sectors, we've seen kind of a mixed picture, how well is technology working in schools and so on. So how is this move toward technology and online working with senior populations, especially maybe immigrant and low-income populations, and what, are there some promising ideas going forward or not?
One of the things that we're working on very diligently, and this is not only in Los Angeles, but across the country, has to do with accessibility to broadband. One of the places where we kind of get stuck is not everybody has access to affordable internet. And so therefore, our ability to deliver programs is severely limited because of that. But I know that at the state level, locally, I'm working with the city to try to, really prioritize older adults as a target population. Right now there's a huge focus has been on children in school. And I can promise you that I'm trying to be the next high priority population that we look at. I'm working diligently with the state of California Department of Aging, who has been on the ground trying to figure this out since day one. And we're really trying to develop infrastructure. You know, we're not only worried about the current situation, but we're worrying for the long term. What are we building that's useful? So we're developing different partnerships with technology companies, but also with innovation leaders in this space who are very interested. I am very heartened that major corporations have reached out to the Aging Network during this time and have said, you know, we want to help. How can we be part of the solutions that you're building? And so that has helped us to really start being more creative and more thoughtful. At the City of Los Angeles, you know, we have an amazing team at the mayor's office and our information technology agency who have, you know, been present in my world since day one, saying, what can we do to help you? How can technology assist what you're trying to do? So I think you're going to see a lot of innovation rolling out in very short term, because everybody has been thinking about how to resolve this for, you know, several months now.
Thank you so much, Laura.
Sure.
So we've heard now from a research perspective and clinical and service providers. I want to turn to you, Paula, to hear your thoughts about both the opportunities for storytelling on this and some of the things that perhaps journalists should be wary about as they wade into this really important topic. You're muted. Oh no, I'm not hearing you. Maybe raise your volume on your computer. You might have your volume on your computer off. I'm still not hearing you, Paula. Another option would be to unplug your headphone and just use the speaker on your computer. Just bear with us a moment.
Okay, how's that?
Oh yeah, I don't see you, but I hear you.
Well, I am not showing that I have stopped. Oh,
You're like the Wizard of Oz behind the screen. That's great. We can hear you.
Yeah, this will work. Or do you want to just quickly try to look on the bottom? There's something that says stop video or start video. And if you...
No, I'm showing that I have video and I'm showing that I'm not muted. So,
oh, well, let's just go ahead then, because we really want to hear from you.
Okay, great. Then I don't have to worry about how I look. It is exciting to see this kind of interest in reporting on aging, because this is it's an area that's heavily researched, but underreported. And when I fell into the aging beat accidentally, as often happens, I was astonished and delighted at how much solid information there is about this vast older population: physical, mental health, their relationships, their tech skills. I'm sure that to people in the field, like Dr. Perissinotto, the amount of information that you still don't have is frustrating. But as an outsider, let me say, compared to what a lot of reporters are trying to find out about, this field is just a trove. And that helps protect us against the kind of squishiness that I worry about when we do trend stories. I always worry about stories where I talk to 5 people or 10 people, and if I had talked to 10 other people, would I have some whole other story? But in writing about aging, I actually feel I feel on pretty solid ground because we do know a lot about this. So I can find story ideas every week just looking through the medical journals, the JAMA titles, New England Journal, Journal of American Geriatric Society. There's a very active geriatrician group geriatrics group on Twitter. There are reports from the government reports from the National Academy like this one. When I took over the New Old Age column in 2009, I thought, well, I could do this for a couple of years and then I would run out of material. And that has not happened. And by the way, the researchers and the people who are working on these issues will be so happy when you call them, and they will call you back and they will give you their time. It's not always like that, fellow journalists, no. So one thing I've learned from all this snooping around is that my sort of motto is extreme heterogeneity. The geriatricians like to say, if you've met one 85-year-old, you've met one 85-year-old. So some of them are running marathons and some of them need help to get out of bed. And so that's a cause for caution too. Isolation and loneliness were real and urgent concerns among older people long before any of us had heard of COVID-19. That National Academy report, which is a good place to start, was commissioned 2 years before the pandemic hit. And now, of course, as Carla Parasinotto's data is showing, these have gotten to be much worse problems. But like a lot of problems that older people face, they are not evenly distributed. So there are stories where our natural desire to shine a light on dark places and to help right wrongs are entirely warranted. But I also don't want us to contribute to a meme about pathetic old people. As I think I am the only person on the panel today who actually is an old person at 71, we are often victimized, but we are not only victims. So one area where I think our spotlight is potent and necessary is when we talk about loneliness and isolation is the nation's nursing homes, and much less written about and also far less regulated and less often surveyed assisted living facilities. In March, they pretty much all shut down. No communal meals, no activities together, and most significantly, no visitors. And of course, they still account for about 40% of the nation's death toll from COVID-19. When you have frail elders, many of whom have cognitive impairment or dementia, cut off like that, alone in rooms all day, having boxed meals dropped off at their doors, that's just a prescription for disaster. And isolation is a real and desperate problem there. One geriatrician said to me, it's not only COVID that's killing these residents. That shutdown probably was a reasonable response in March and April and May, but now there's reason to consider whether it's too restrictive. The Centers for Medicare and Medicaid, CMS, have issued guidance on how to safely reopen to visitors, but in most places, isolation remains the policy. So now geriatricians are saying to me, there should be ways to safely permit designated family members, not everybody. You take one person or a couple of people per resident, you train them in the use of protective equipment, you test them, and then you let them in. And there's a study from the Netherlands that shows that it is possible to do this without increasing the COVID infection rates. Because family members who visit nursing homes are not just paying social calls. They are an essential part of taking care of the residents of these nursing homes, which we know are chronically understaffed. So it's not enough to let them see their relatives through the window. They're the ones who are helping to feed them and dress them and keep them oriented. They're monitoring their health. They remind them of who they are. There are facilities like this in virtually every city and town where you are. And it's an example of a situation affecting elders that I think deserves our attention. I was stunned when I did a study on robotic animals, robot cats and dogs, animatronic pets. Some states are using public money to purchase these for nursing home residents. Is that a solution or is it an indictment? But let me also point out that despite all the challenges and the heartache, including a lot of death of our peers, older people also have resilience, and they are not always the people that are suffering the most from the pandemic. So look at mental health problems, because depression is one of the problems associated with isolation and loneliness. But when the CDC published a large national survey of reported mental health problems in June, it found, yes, a lot of anxiety and depression, but not nearly as much in the elderly as in the younger groups. So among those 25 to 44, which we think of as prime time, about a third of people reported these symptoms. Among people 18 to 24, it was almost half reporting anxiety and depression, and over 65, it was in single digits. Now, Carla's work shows a different picture. The Kaiser Family Foundation analysis put the figure in August, much higher than that for older people at about a quarter. And that's a scary number to have depression, but it's still far lower than among the younger people. Older Americans have been through a lot. They know how to modulate their emotions. This is the work done by Laura Karstensen at Stanford years ago. They have some experience in writing out hard times. I'll refer you to an editorial in JAMA the week of December 8th. The first author is Ipsit Viha. It's spelled V-A-H-I-A at Harvard and McLean, suggesting that the negative effects of loneliness may be partially countered by various kinds of coping mechanisms that older people have developed over time, and by wisdom. And qualities like that can sound kind of woo-woo can actually be measured, I was astonished and delighted to find, by social scientists, things like purpose, gratitude, wisdom, and these are part of older people's lives. And they in many cases can provide a kind of resilience that doesn't quite square with the notion of the poor, lonely old person. In fact, I wonder if some of the dislocation that older people have to cope with during the pandemic isn't only isolation, but loss of purpose. Most elders aren't working. And so they found purpose in things like volunteering, but volunteerism skews very heavily towards older ages and people who are retired. And many also played a role in caring for family. And now the family is worried about infecting their older person, and so they're trying to pull back from that. So losing purpose is also a difficult thing, and it's hard to rebuild your weeks and your months to recapture that. On the data, on the technology side, it is true this is a real divide by education, by income, but we also have seen in recent months older people just stampeding onto these video chat platforms to stay in touch with their families, to have a Seder, to hold virtual book clubs and virtual bridge games. And anecdotally, we're hearing about elders working not only to navigate the pandemic themselves, but to help one another, either through programs or just informally, individually, keeping in touch with people, being on the phone. So there's probably more room here for coverage of how elders adapt. So I take isolation very seriously. I look at Carla Perisinoto's data and it's grim. But I'm also warning against the overly broad brush. I would like us to portray elders in all their complexity. And I think you may find that it's not that hard to do.
Paula, I'm so grateful that you brought up some of these topics, because I think you're right. Some of the emerging data is actually looking at younger populations of actually having even higher risk than older adults. And I think the topics you're talking about, resilience and purpose, are things that we in the medical community can learn so much more from our social scientists and are just starting to get at some of these issues. And you're absolutely right of the comment about heterogeneity, and that's such an important term, which is why when we think about solutions, we can't assume that the solution is going to fit everyone. And as you said, that every 71-year-old is the same or every 85-year-old is the same. I find that very, very important to keep at the forefront. So thank you. Thank you for making those comments. I will also note for those on the line that I'm actually involved with an international research collaborative, and we're actually looking at some of the experience of COVID during the pandemic internationally. We have preliminary studies, and so I think that'll tell us a little bit about, what we're doing here versus what we're doing internationally. And with regard to the assisted living world, thankfully, we're seeing some improvements, but what's really hard early in the pandemic, and unfortunately, I spoke out perhaps a little bit too loudly about the failure of the CDC early on to have recommendations specifically for older adults and specifically for assisted living. So it's been a huge a gap in the guidance. And many assisted livings are working with either being afraid of family members and suing if someone gets sick, and then on the flip side, restrictions. So it's this tough balancing act, and I absolutely believe that there's a way to do it safely.
So, oh, great, Polly. Oh, you briefly reappeared. I want to open this up to everybody's question. Just a reminder that you can put questions in the Q&A field. And while we give you a moment to do that, I want to follow up on something that Paula said about the CMS recommendation for isolation, and that remains the official policy. We've seen a lot of really powerful journalism on this. I'm thinking of a story by the author Min Jin Lee in the New Yorker about her Korean immigrant mother being cut off from all the kinds of support that Paula just outlined, in her sort of desperate effort to get somebody to help her in a facility. Do you, Carla, and you, Laura, think that is a mistake, the way that we have handled this? Or where should we be now that we know more about the disease? I mean, where should we go forward on that question of protecting people from COVID,
Right.
not, risking such dangerous isolation?
I think that it was necessary early on because we were just learning. We were learning more about transmission. We were learning about incubation periods. But I think we're in a different place. That being said, I can tell you from my own healthcare institution, we're having to revisit visitor policies because of visitors potentially not abiding by wearing PPE. So, so that's one of the challenges, because then you're exposing everyone else. And so when we allow visitors, and if we train them, but then who's to say, that they're not going to take their mask off while they're in the room with the person, and then that exposes people. So there is a way to do this. But I think people reacted out of absolute fear initially. But now there's a way to do this by either monitoring visits in terms of the PPE, staggering visits, keeping very careful track of who's coming and going for contact tracing precautions. So there is a way. I think what happened early on is that there was no guidance. And so there was no assisted living that wanted to say, well, we're going to be the first to let everyone in. And for me as a geriatrician studying isolation and loneliness, I knew this was a problem, but I also was not ready to say, okay, everyone, open the floodgates. And so it's more of a trickle on how to make it done, have it be done safely.
Our experience in working with the facilities was, as you said, one was a precaution and care and concern for the well-being of their residents. I think right now people are looking for different strategies and solutions where they can make their locations more accessible. I think I had shared in our preparation call that my mother actually was placed in a nursing home on March, I think it was 20th, because she experienced a fracture, and the facility was closed. But one of the things that they did within 2 days of her arrival, they had a nursing assistant walk around with her cell phone so we could do FaceTime. And she did that every other day. So when I couldn't get a hold, I would talk to her on the regular phone, and then I would get to see her. And that was a facility reacting in real time, very quickly, to ensure that they were not disconnecting their clients. And I have seen a lot of my colleagues that I've been reaching out to in the nursing home industry and assisted living that were doing very similar efforts very quickly. So the shutdown was maybe physical, because I can tell you it was traumatic to me, but it was also not exclusively that you were not going to get to see them or talk to them. It was just facilities reacting to the requirements. And now they are looking for those protocols and opportunities to make it safe for everybody that's there, because we've been working with a group looking at ways that we can, design facilities in the future from the lessons that we're learning right now. And so the opportunity is there, and I am seeing an opening and an interest in providing quality of care.
I think
I'm sorry, go ahead, Carla.
As a follow-up too, I think, as geriatricians, we're trying to be more at the table in terms of making sure that we're included in discussions and policy decisions. I mean, it's fascinating early on how here was a pandemic that was having the greatest mortality in older adults, yet geriatricians weren't really contributing to policies and procedures. So we're trying to do that. And also as a follow-up to the technology, And an answer to a question in the chat, which is with the technology, is where we've seen improvements is actually having dedicated staff, for example, on the healthcare side, to really help the older adults connect. So we early on spent hours and hours troubleshooting with patients to be able to get onto technology and talking to our patients in assisted livings or nursing homes so that we had a dedicated person that could allow us to do the video visits.
Thank you. And we're going to turn to a question from Liz Siegert, who says, as the case rates continue to climb again, do you anticipate that CMS and or governors may initiate shutdowns of nursing homes and assisted living facilities again? And how will that impact those residents, especially after some visits had begun again?
If I can respond, I think CMS leaves this a lot to the state. So they have their guidance, but it's not enforced. The states decide how they're going to respond. And then often, depending on how states regulate, the states leave it to the facilities. So the idea that this is coming from the top is often not true. And with this assisted living, it's even more catch as you can because they're not federally regulated at all. So, when this, and I think the fear of liability is coming into play here a lot. So when CMS says you can't let visitors in until you've gone 28 days without a single case in your residence or in your staff, that's a way to just never let people in. But every nursing home and most assisted livings have, first of all, there are long-term care ombudsmen in these communities that are supposed to represent families and residents. And there are also very often family councils and resident councils in these facilities. So I would like to see some of the families and residents organizing themselves to deal with their own administrations about how they can start, and would make sense to consult with geriatricians in the community to see if we can get off the dime here, because if you're waiting for CMS to say it's okay now, you're going to wait a long time.
That's right. And let's go ahead, Laura.
Oh, I wanted to share just our local experience. We haven't, I totally resonate with Paula's statement. We haven't left it to other people to tell us what to do. I have been reaching out to our public health officials, to our ombudsman, who I work with very closely, to our nursing home facilities, because we want to be intentional and proactive rather than waiting for somebody else to tell us what to do. So I'll tell you, when they closed the facilities and ombudsmen were not considered essential workers, so they couldn't go in, our ombudsman locally sent over 80,000 postcards into nursing homes to residents in Los Angeles to say, I'm out here, this is my number, you need me, you can call me. That was a way of sort of trying to go in without being allowed in. And we have been trying, to put technology in facilities so people could talk to their loved ones and other relatives, and also to the ombudsman. So we have been very proactive. I can tell you, I read every policy statement or regulation that's written by a public health official. And I have on a couple of occasions picked up the phone and the email and said, did you anticipate that this would work this way with a cognitively impaired older person? And knowing that the person that was perhaps developing that statement was not aware of how older adults may experience that regulation or that specification. And so it really is also up to all of us as advocates and leaders in communities to become part of the solution rather than waiting for things to magically appear.
I was going to say that I think, this event is somewhat relevant to the National Academy of Sciences study too, because as an example, UCSF has partnered with Welltower, which is one of the organizations that owns quite a few of assisted livings around the country. And we have been providing actual guidance for several years now, for 3 years, starting with flu. And then we actually transitioned it to COVID guidance. And what we found, and this is not universal again because of heterogeneity, but many of the assisted livings really were looking for guidance because there was nothing out there. So they turned to us as an academic institution with expertise in infectious disease and geriatrics to say, can you please guide us on when we didn't know about PPE and what we needed, and how do we do reentry and how do we do testing. And so it's an opportunity when there's a lack of regulation, which sometimes is a good thing from the federal government, to actually think about creative strategies. But it's scary. And I can tell you, in April, as a geriatrician, when I was getting asked, it was, when there's no data, at some point there's some level of risk it's risk mitigation. And it's ultimately, what level of risk are we able to tolerate, and what risk are we talking about? Because there's the risk of COVID and there's the risk of isolation, and both of them are bad, frankly.
We have a question from Sherry Geyer, but from others also asking about rural health. Sherry says she writes about the topic. And do you see these social isolation and senior issues as affecting rural and remote communities? And if so, how? And are there specific issues rural health professionals should be aware of and how to respond?
There are, and I don't know this literature as well, but absolutely, some of the literature really does look at rural versus urban communities. But again, if you think about, again, the factors that go into why someone is lonely or isolated, if you think about this being a structural issue, for example, so transportation in a rural area may be similar to someone in San Francisco or in New York in a third floor walk up that can't get down the stairs. In some ways, the issue is the same as getting out of the home. And so the challenge, I think, more in rural areas is availability of resources. So this is where sometimes technology may be a better solution, or phone-based programs, but the outreach or the number of people you can target when if it's an in-person thing may be more challenging in rural areas. But this is an example of where the research needs to go in terms of understanding subsets of populations or sub-environments, not sub-environments, but other environments, and how to intervene more effectively.
So we have a couple of questions about solutions. Ellie Bogley says, can you address solutions, and most importantly, how to convince local municipalities to provide funding to improve services to seniors? And Dina Montez says, nationwide, what have been the best practices in cities in limiting social isolation? She goes on to say, in New York City, we have 171 senior centers doing virtual programs. And we have a volunteer-based program where volunteers are paired with older New Yorkers to regular calls and video chats.
I will recommend that folks that want to sort of find out what's going on across the country reach out to the National Association of Area Agencies on Aging. They have been capturing best practices across the country and creating like small briefs. So if you're interested, I'll reach out to the National Association of Area Agencies on Aging, and they will be able to put you in contact with specific localities and specific programs that have demonstrated best practices. That would be my recommendation.
I think as a follow-up, I would say there's two parts here in terms of what's best practice based on what we know and what are the unknowns. And from the National Academy of Sciences report, there's quite a few unknowns, and there's a huge gap in the literature in terms of really knowing what actually is effective, both clinically and statistically and practically. So right now, I think we're in the pragmatic stage, which is what do people think is working nationally, and then work on getting the data. And as a researcher and clinician, my biggest push to people is really try to evaluate your program so you can show that they work. And this is what will ultimately encourage governments or local agencies or local programs to support local programs. What we're seeing in the private sector is there's a lot of movement here in for-profit companies because they are able to show return on investments that unfortunately the public sector is somewhat slow to do. So that's another area for us to keep working on.
In Los Angeles, one of the things that really helped was that in 2016, we launched our age-friendly initiative for the entire region called Purposeful Aging Los Angeles. And as a result of having spent 2 years before the pandemic, really engaging over 300 community stakeholders and leaders, 21 elected officials, when this happened, it became almost, it feels like it was very easy to connect, to educate, and to mobilize our elected officials in terms of the supports that we needed. And because they were already versed and understood, aging was a priority in our municipality as well as in our county. And so folks really responded in a very timely basis. And there wasn't all the barriers that we would have had 3 years ago because they didn't even understand what we were talking about. Because of all the foundational work that we did, we were able to mobilize in real time because we had this infrastructure that helped us move forward. And so if I have a recommendation, is to really look at how do we disseminate the importance of creating age-friendly initiatives in communities, because it serves us well as we begin to look at infrastructure within the local areas for how to improve service delivery. So that would be, one of my takeaways out of all of this was, if I had not had purposeful aging, the work would have been arduous compared to how hard it already was. It would have been 10 times harder. So it really helped us a lot.
And before I'm sorry, go ahead, Paula.
We've seen around the country municipalities trying to use existing organizations like libraries. Libraries are patronized very heavily by older people. And so to have the library staff, even if you can't go in, trying to call people, trying to bring books to people. We've seen YMCAs do this. We've seen Meals on Wheels program, not only dropping off the meals, but trying to have some distanced interaction at the door so that at least you have a little conversation. In LA, I was impressed at the Motion Picture and Television Fund, which, okay, it has a lot of money, but it has a telephone or a way of putting people in touch with each other intergenerationally within an industry. So then it's like, I'm not just calling the poor old person, like I'm calling somebody in my industry, like, we're colleagues. So I've seen a lot of creativity around it. As Carla says, we don't know what it's doing yet. But we see people trying in all kinds of ways to use what we already have to try to meet this new need.
And before we go on to what will be our next and final question, I just want to follow up with you, Paula, on something, which is, since we're talking about solutions, you had mentioned to us previously that you get a lot of stuff in your inbox peddling, so-called solutions. And so what advice do you have for journalists so they don't inadvertently become hawkers of someone's product?
The minute you write anything about aging, you will be hearing from half of Silicon Valley about, here's our fabulous new app. Here's our new platform. Here's how we're going to keep people in touch. And I have an easy responses, which is, I don't write about products. But the other thing I say is,
show me the data.
Give your fabulous new device to 200 families, follow them for 6 months, and then get back to me.
Right. Exactly.
Because a lot of, there are all these programs that would like to enlist you in their PR efforts, and we just say no.
Paula, just so that you know, they are listening to you, because several of the high-tech companies are doing just what you said.
Yeah.
Fabulous.
We are telling them the same thing that we are not here to promote particular products.
Right.
But we are more than happy to accept gifts for us to try pilots.
Right.
They are taking us up on it. And I'm very delighted to be able to share that with you, because that is also one of the ways that we can more objectively look at products when we do not have commercial interest in them. So.
And this again is where, we're trying to advise them again with the National Academy of Sciences report, is like, what is the theory behind what you think is working, and show me that it works. I mean, a lot of them reach out to me as well. So Paula, I'm glad to know I'm not alone in the outreach, that they're outreaching to you as well, because it gets a little bit hard week after week to get these solicitations of, what's the app du jour.
Right.
I said I was going to do one question, but I'm going to sneak in one other one too. But let me start out with one from Susan Jaffe, who says, in addition to the trend and study stories, the Aging Beat offers great opportunities for traditional news stories. How can reporters get better access to the latest changes in nursing home regulations when CMS is usually not inclined to inform media? For example, CMS, Centers for Medicare and Medicaid, requires nursing homes to expand end-of-life visits when someone is expected to die soon to situations where the resident is, quote, experiencing emotional distress, a decline in well-being or physical health, needs a family member's encouragement, and so on. And, how does that apply? And that was being sent out, but not to media. So I don't know, is there some way to track these kind of things for somebody who's maybe not on the mailing list of geriatricians or something?
I haven't had that issue. I have found CMS to be, not always willing to get on the phone, but will, reasonably happy to just send you whatever they're publishing. But I think that ombudsmen in local communities have access that we don't always have. But the biggest single source is families. The families of the people who are residents. They are really on the case. And whatever it is that CMS says, they know what's actually being done and not done, and they want you to pay attention. So I think to link up with ombudsmen and families locally gives you a much deeper understanding of what the reality is on the ground.
Yeah, I mean, and there are CMS listservs. I mean, they're painful to read, but at least it gives you a hint of what's actually written. And then, as Paula said, like then it's getting on the ground what's actually happening. But yeah. There was one I got this week and it was like, please read the guidance. And it was like 400 pages. I was like, yeah, of course. In my spare time, let me read my 400 pages of this guidance that makes no sense. And at the end, it'll be like, no change. And you're like, great, that was so helpful.
Yeah. And then the final question is from Millie Lagraine, who says, you had mentioned there's a data gap for people of color and that there's a language barrier, but do you have any data on how the issue is affecting the Latino community?
There are pockets of data for individual communities of color, and there are some in the Latino community, but it's too big of a topic to kind of address here in terms of, it just depends on what we're talking about. Yes, there are some solutions specifically for Latino adults. It probably depends on, are you foreign born or US born in terms of how you define yourself, what are you looking for? So we're getting there, but there's still a long way to go. And part of that, again, starts with communities like LA being led by Laura, who specifically looks at and makes sure that we are capturing this information and serving people of all groups.
And I wanted to recommend a good place to start is, for example, the University of Southern California School of Social Work has the Roybal Institute on Aging. It's an applied research center. UCLA has LA Capra, which is also an applied research center. And I would recommend, if you're interested in ethnic minority populations and impact of aging or anything, those are really good places to start, because those are where we have anchors of researchers that look at those populations ongoing.
Thank you. And with this, I'm going to conclude our webinar. I want to thank our fabulous panelists and also our participants who've been entering into the Q&A, all kinds of really interesting resources. I'm not sure if everyone can see them, but I hope so. And we want to thank the California Endowment, the Commonwealth Fund, and the National Institute for Healthcare Management Foundation for supporting this program. And we also want to express our appreciation for donations to support this work from individual participants like you. And should you want to lend a hand, we've tripled the number of webinars that we hosted this year because of the pandemic. You can just send a text to 41444 and help us to do more. So we will be archiving this webinar a little later today, and we'll be sending you a survey. Please take a moment to fill it out to tell us what you liked about this webinar and what topics are of greatest interest. This is going to be our last webinar of the year, and I want to wish everybody a happy holiday season and to stay safe. And vaccines are just around the corner, so have some hope. And let's all hope together for a better 2021. And thank you so much for joining us.
Thank you.
Thank you.